Welcome! This module is the main education module. It has the most detail specific to mental health and substance use, and also includes sections specific to what we actually see at Dave Smith Youth Treatment Center. Don't worry, everything after this one is much smaller. The concept behind these brief information segments and videos would be to not only educate the caregivers or potential youth clients, but to provide comfort in the knowledge that while their personal accounts are completely unique, they are not utterly alone in their experiences. These segments will consist of some original content, as well as videos from various sources that discuss evidence-based information, definitions, and explanations of basic concepts of mental health, mental illness, and substance use. Moreover, data from the center will be included to showcase what the agency often observes, its theoretical approaches, and how it functions in general. The first introduction videos should provide information that helps the person watching understand the basics of substance use and mental health, what disordered mental health and substance use is, whom it affects, and perhaps most importantly, why and how it happens to us, progresses, and its connection often concurrent with mental health. Further, the separate units discuss an overview of ACRA as our guiding theoretical framework to treatment. Understanding what and how the adolescent community reinforcement approach works is imperative to those planning on treatment or simply seeking information. This overview can then be used to break down and define the different units to be constructed in the future for caregivers with therapists or family therapists. Understanding emotions and behaviors, including connections of thoughts, feelings, and actions, the validation of emotions, and learning that behaviors are often a symptom of emotions. This will segue into motivation and the process of change, including the cycles of change and how one can become motivated to change. These can be facilitated by demonstrating healthy communication, including different styles like assertive, aggressive, passive-aggressive, and realistic comparisons of poor communication. Safety within the family and in regards to oneself will be discussed. And finally, self-care will be discussed as well, containing definitions and methods to not only care for oneself, but to help build coping skills and resilience. Prior to or following the units will be an introduction and conclusion from the center that serves to promote how this information is used within the agency, how it relates to the clientele, and how ACRA is used in these instances. This will aid in the promotion of the agency and showcase the uniqueness of both the clientele and its approaches. ACRA and CRAFT can then be broken down into separate units like problem solving, communication, etc., for the purpose of creating units for the caregiver to complete while their youth are in treatment. This will promote evidence-based knowledge and aid with therapeutic interventions. For example, creating more timely sessions with addictions therapists and family therapists for caregivers during their youth's journey. The following section should attempt to answer questions staff at the center often hear from clients or caregivers in regards to substance use. A common question and answer that should remain at the forefront of this discourse is, what is the disorder and why me? How did this happen? So what is mental health versus mental illness? Firstly, before getting into the details of mental health, it may be important to understand the definition of health. In this case, it can be understood by the long-standing definition provided by the World Health Organization, which states that health is a complete state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. So we can think of health as being multidimensional, not just sick or not sick, but many different aspects of our lives contributing to it, an overall sense of well-being. Mental health is part of our overall health. and can be understood in the same way. It is not just the absence of a mental illness, but a combination of factors that make up a sense of mental well-being. These factors can include our thoughts and emotions and the connection between them, feelings of connectedness to others, and being able to cope with life's highs and lows. Here's where it can get confusing. Having a mental illness does not necessarily mean one has poor mental health, but it can contribute to it. There are a host of factors that combine with mental illness that can lead to poor mental health, just as there are many factors that can help reinforce positive mental health, even with the presence of mental illness. Therefore, although we often hear the terms mental health and mental illness used interchangeably, it's apparent that they're not the same thing.
Mental health is an important part of our overall well-being and is something we all can play a role in addressing. It's a subject that deserves our attention. According to Statistics Canada, 1 in 3 Canadians will experience one of 6 mental illnesses or substance use disorders in their lifetime. Other research for the Mental Health Commission of Canada shows that, in any given year, 1 in 5 Canadians will experience a mental illness or addiction. Awareness has been raised about the importance of helping those experiencing mental illness to get access to treatments that will improve their mental health. But what about the 4 in 5, or 80% of the population, who will not experience a mental illness or an addiction? What about their mental health? Are they mentally healthy? First, what is mental health? There is some confusion about what mental health means, and this can have an impact on how we address mental health. For example, a lot of people think that when we talk about mental health, we're talking about mental illness, that these subjects are one and the same. Really, mental health and mental illness are 2 different things. Mental illnesses are conditions where our thinking, mood, and behaviors severely and negatively impact how we function in our lives. Mental illnesses can include depression, anxiety, schizophrenia, and other mood disorders. Mental health, on the other hand, like the term health, is a positive concept. It relates to our ability to enjoy life and to manage it in ways that help us reach our goals and cope with stresses. It's a sense of spiritual and emotional well-being. This means mental health is more than the absence of mental illness. Now, if mental health and mental illness are 2 different ideas, what's the relationship to one another? Sometimes, people picture mental health and mental illness being 2 ends of a continuum, as if one is the opposite of the other. But a lot of research shows that we should think about mental health and mental illness as separate yet interconnected concepts that need to be looked at, measured, and responded to differently. We should think of them on 2 separate continua. So here's what the mental health and mental illness continua really look like. On the mental illness continuum, one end runs from severe mental illness to no mental illness. On the mental health continuum, one end runs from poor mental health to good mental health. This model shows that a person without mental illness is not necessarily mentally healthy. They may be feeling down or experiencing a high level of stress because of life's circumstances. But it also shows us that we can all strive for good mental health, that even individuals with mental illness can have good mental health. Let me give you an example. This is Tara. Tara has been diagnosed with depression, a potentially severe mental illness. However, her depression is now under control. She's on medication and sees her psychotherapist regularly. She likes her job, feels capable of completing her work, and is able to eat right, sleep well, and exercise. She feels comfortable and respected in the places where she lives and works, and she feels like people in her life love her and understand her. Despite her mental illness, Tara has good mental health. So how do we promote mental health? How do we make more people mentally healthy? While there are things we can do to take care of our own mental health, the community where we live, work, and play has a big impact on our mental health. A community can promote mental health when its members have access to good jobs, incomes, and housing. A mentally healthy community makes people feel safe and secure and like they belong because it's inclusive of people with different ages, backgrounds, genders, languages, and sexualities. There are simple things that you can do to help create a community that is mentally healthy. Know and accept that everyone faces daily challenges. Get involved in your community and give back. Support and include different types of people in your community. Finally, there are many things that you can do to take care of your own mental health, whether you have a mental illness or not. Know and accept that life can be challenging. Create purpose in your life by learning and trying new activities, like starting a hobby and setting realistic goals. Create healthy, trusting relationships with people who accept and support you. Know and accept your strengths and weaknesses. Accept yourself and others. It's the basis of self-esteem. And learn to recognize and understand that you and others have good and bad feelings. By increasing good mental health, all of these things contribute to the overall health of Canadians. Like the World Health Organization famously said, there is no health without mental health.
Have you ever wondered about the difference between the terms mental health, mental distress, or mental illness? The language out there can be confusing, and sometimes even conflicting. When we use phrases such as mental health issue, mental wellness, or mental problem, no one really knows what we're talking about. Using the correct language not only helps us to intervene more effectively, but it also reduces stigma. We've got a tool to help everyone get on the same page when it comes to talking about mental health. We like to think of it in terms of a pyramid, with these 4 different states. Everyone falls somewhere on the pyramid, with more people on the bottom and less at the top. In the bottom category, we have no distress or no problem. Everything's going fine, and we're generally enjoying ourselves. We may be spending time with friends, attending school, or even sleeping. One level up, we have mental distress. Mental distress refers to the everyday problems that we encounter. These are things that irritate us, things that we're worried about, or problems that come our way. For example, we might have an upcoming presentation to give, or we may have had conflict with a friend or had a flat tire. When this happens, our brain sends us a signal. It's called the stress response. Our stress response is the basis of resilience and adaptation. Once we successfully solve the problem, the stress response usually goes away because we've developed the skills we needed to adapt. We don't want to go out of our way and protect ourselves from these normal stressors of everyday life, because problem solving through these stressors is how we ultimately develop resiliency and the capacity to become successful adults. But oftentimes in life, we're faced with problems in our environment that are simply too big for us to quickly solve or deep breathe our way through. That's what we call a mental health problem, which is the 3rd level up in the pyramid. Mental health problems are serious events such as a parent dying, having a divorce in your family, moving to a new country without sufficient resources. Mental health problems may keep us up at night. They may cause intense emotions, and they may last for a long period of time. But remember, they're normal. These are difficult times when it's important to reach out to others for help. Mental health problems may require the support of friends, family, counseling, or just time. The top of the pyramid, reserved for the fewest number of people, is a mental disorder or mental illness. This includes diagnoses such as clinical depression, clinical anxiety, or bipolar disorder. A mental disorder is very different than a mental health problem. This is where we see something going on in the brain, a perturbation of usual brain functioning. This is where evidence-based medical and therapeutic treatment is needed by specially trained professionals. Remember, the pyramid is not a continuum. Mental distress does not necessarily lead to a mental health problem or to a mental illness. In fact, we can even be at each level of the pyramid at the same time. For instance, someone can have ADHD, a mental disorder, be grieving the loss of a loved one, mental problem, have an upcoming exam that they're worried about, mental distress, and sometimes they can just forget all about it and feel fine. All of these levels or components of the pyramid are part of our overall mental health. We need to make sure that we don't define good mental health as never having a bad mood. Good mental health includes a wide variety of emotional states. There are times when we are frustrated, indifferent, happy, sad, lazy, joyous. These are all parts of life and normal fluctuations in our mood. If a person has a mental illness, it doesn't mean that they lose their mental health. So let's start using the correct language, because it really does matter. Depression is not the same as feeling sad, and ADHD is not the same as being hyperactive. When we speak from a common framework, we're reducing stigma and building the foundation for better mental health care for everyone. To learn more, check out teenmentalhealth.org.
Mental illness is what many may typically think of as having disordered mental health or a mental health disorder. There are numerous types of mental illnesses that affect many people in a variety of ways. It would be much too time-consuming and complex to touch on them all. However, it may be beneficial to know that in a given year, mental illness will affect 1 in 5 people. By the age of 40, 50% of people will have had some experience with mental illness. Although there are factors that may increase the risk of mental illness, like socioeconomic status and systemic inequities, the disorders themselves do not discriminate. Anyone can be affected. This will be a recurring theme in these online resources, but know that you and your loved ones are not alone.
Mental illness can affect anyone. Mental health affects how we feel, think, and act. It's important at every stage of life so that we can cope with stressful situations, work productively, and make meaningful contributions to our community. However, the statistics are staggering. Over 45% of teens suffer from a mental disorder, and 1 in 5 teens suffer from a severe mental illness. That's 20% of our teen population. Mental illnesses are brain function disorders. They have many causes and result from complex interactions between a person's genes and their environment. A person struggling with mental health should not be viewed any different than if someone were experiencing a physical illness. Mental illness is not a choice or a failure. It does not discriminate. It can affect anyone, regardless of age, gender, social status, ethnicity, or any other aspect of cultural identity. In fact, mental illnesses occur at similar rates around the world, in every culture and in all socioeconomic groups. The concern with mental health isn't just about the statistics. It's about well-being. It can affect families, friends, and our communities. But you can help make a difference by learning to recognize the signs of mental illness. A mental illness makes the things you do in life hard, like work, school, and socializing. It's also not always clear when a problem with mood or thinking has become serious enough to be a concern. Sometimes a depressed mood is normal, such as when a person experiences the loss of a loved one. But if that depressed mood continues to cause distress or gets in the way of normal daily functioning, the person may benefit from professional care. If you think you or someone you know might be struggling with their mental health, it is best to consult a professional. Early identification and effective treatment is key to treating a disorder and preventing future disability. A healthcare professional will connect symptoms and experiences to help formulate a diagnosis. Suicide is the second leading cause of death for young people between 10 to 24. If you're thinking about suicide, are worried about a friend or loved one, or would like emotional support, call 1-800-273-8255.
The Diagnostic and Statistics Manual of Mental Disorders, 5th edition, which we'll later refer to as the DSM-5, is the guiding diagnostic classification system in Canada and is used by professionals to diagnose mental illness. However, it is important to understand that a diagnosis of a mental illness is not a label. These diagnoses are simply used by professionals to better guide their treatment and to choose the tools from their toolkit to offer you for your own toolkit. Think of it like repairing a car with the check engine light on. A mechanic would need to diagnose where the problem is and decide what parts need fixing and what tools are necessary to fix it. A positive outcome of this is that you now know what the warning signs are and may have gained some knowledge or tools on how to help deal with the issue should it happen again. At the center, the majority of our youth live with some form of mental illness, such as feelings of depression, reported by 100% of our clients, suicidal ideation in 81% of our clients, or anxiety in 79% of our clients. To address this, a variety of evidence-based interventions that show effectiveness with various mental health concerns are employed. While the Adolescent Community Reinforcement Approach, or ACRA, is the foundational framework, other interventions that are designed for specific mental health concerns are also employed. For example, dialectical behavioral therapy, called DBT for short, is a form of cognitive behavioral therapy designed for use in treatment of borderline personality disorder, or BPD. However, this intervention technique has also been shown to have benefits beyond the disorder it was designed for, such as an increase in positive emotions regarding post-traumatic stress disorder, or PTSD, and anxiety, as well as BPD. This is just one example of how the Center employs a variety of evidence-based interventions to treat the whole person, not just the symptom. While substance use disorder or addiction, and please note these terms will be used interchangeably, may be a somewhat controversial topic among some, it is important to know that it is a mental illness diagnosable in the DSM-5. Furthermore, research shows that addiction can be considered a health issue and, like mental illness, lies on a spectrum or continuum that we were all on. Depending on a variety of internal and external factors, we are more or less at risk or more or less resilient to substance use disorder. We will touch on these factors later. Maybe even more important to know is that all these factors can change and are ever changing. With social support, psychoeducation, and therapy, in dealing with the underlying issues like trauma or mental illness, we can become more resilient or less at risk of disordered substance use.
Welcome to this module on understanding substance use. In this module, you'll learn about the spectrum of substance use, the nature of problematic substance use and substance use disorder. You'll learn about the connections between brain development, adverse childhood experiences, and substance use, and you'll gain an understanding of how resilience is built and harm is reduced. You'll also learn ways in which educators like you can support youth. Use this module alongside your educator's guide, which provides additional information, tools, and resources to support your learning. Let's begin. Alcohol is the most commonly used substance among youth in Canada. In 2019, almost half of young people in grades 7 to 12 said they used alcohol, while 18% said they used cannabis, making it the second most commonly used substance among youth. Youth tend to use substances such as alcohol and cannabis for a variety of reasons and to varying degrees. Some do so out of curiosity, to feel good, or because of peer pressure. Others do it to relieve stress, anxiety, or pain, to enhance academic or physical performance, or even to rebel against their parents. For many, their use is experimental and low risk. For others, it may lead to addiction. To be less stigmatizing, we now call addiction problematic substance use or substance use disorder. Substance use varies from person to person. It can range from no use, beneficial use, or casual use, to problematic use, to a substance use disorder. This is known as the spectrum of use. People may use one substance alone or more than one substance at the same time. This is known as polysubstance use. The way they use these substances can also vary along the spectrum. For example, a person may engage in problematic use of alcohol and casual cannabis use. Let's look more closely at problematic substance use and substance use disorder. Not everyone who uses substances will develop a substance use disorder, but anyone can experience problems with substance use, whatever their age. And people can develop a substance use disorder with any psychoactive substance. This includes substances that are socially accepted and widely available, such as alcohol and cannabis, those prescribed by a physician, such as medications to manage pain or ADHD, and illegal substances like heroin, cocaine, or methamphetamine. The risk of developing problematic substance use or a substance use disorder varies from person to person and can be influenced by a number of complex factors. These factors include a person's genetic profile, family history of substance use disorder, social or economic influences such as poverty, isolation, discrimination, and racism, and trauma such as violence or chronic stress, especially at an early age. It is important to note that just because someone has risk factors, this does not mean they will develop a substance use disorder. These factors can simply increase their risk. Most people don't choose to use substances to the point where it is harmful to their health and well-being. Common misconceptions are that people who develop a substance use disorder don't have the willpower or motivation to stop using, and that substance use is their choice. This just isn't true. Research shows that the brain is designed to adapt and respond to its environment and the conditions it is exposed to. Regular substance use can lead to changes in the brain, causing some people to develop problematic substance use or a substance use disorder. Let's take a look at how substance use affects the brain. The part of the brain located behind the forehead is called the prefrontal cortex. One of its functions is to regulate the fear and reward pathways in our brains. The reward system is triggered by things like food, sex, and social connection, things that affect our survival. When we engage in these activities, a chemical called dopamine is released into the brain. Dopamine influences our mood and makes us feel pleasure. Alcohol and other drugs also stimulate this reward system, flooding the brain with dopamine. When something makes us feel good, we want to do it again. But over time, the brain responds by building up a tolerance to the substance. When this happens, more and more of the substance is needed to produce the same feelings of reward. When a person has problematic substance use or a substance use disorder, The brain's reward circuits or neural pathways are changed so that the brain makes getting this extreme reward experience a priority over pursuing any other needs. This process can cause the decision-making and impulse control functions of the prefrontal cortex to become impaired. This makes it difficult to stop using substances, even when a person wants to. To understand problematic substance use and substance use disorder, it may be helpful to think of the 4 C's: compulsion, cravings, consequences, and control. Compulsion refers to compulsive or repeating behaviors in order to seek out the substance in spite of negative or harmful effects. Cravings refers to physical cravings for a substance that feel the same as the need for water or food. Consequences refers to the continued use of a substance in spite of negative consequences. And control refers to the inability to control use. In other words, trying to stop and not being able to. When all 4 C's are present, a person is thought to be using substances problematically and would likely meet the criteria for a substance use disorder. Critical brain development occurs during adolescence, making youth particularly vulnerable to the short and long-term effects of alcohol and other substances. Substance use in youth has been linked to changes in brain structure, function, and cognition. These changes can have immediate and long-term negative impacts on factors such as academic performance and social functioning. These impacts can extend into adulthood. The experiences we have early in life affect how our brains develop. Being exposed to positive interactions builds resilience and a foundation for healthy brain development. This leads to improved learning, behavior, health, and social well-being throughout life. Stress is another major factor that shapes how our brains develop. Events that create positive stress, like the first day of school or meeting new people, can be healthy when supportive adults prepare a child for future challenges. In contrast, traumatic events like having an accident or losing a loved one create negative stress. Negative stress can have a lasting impact on the developing brain of a child, but a supportive adult can help to buffer the stress response. Exposure to stressful and traumatic experiences over a long period of time, also known as toxic stress, can disrupt healthy brain development. This happens when a child has no supportive adults to buffer the response to trauma. Examples of trauma and toxic stress include neglect, abuse, parental substance use, bullying, or violence. When they occur before the age of 18, these events are called adverse childhood experiences, or ACEs. Young children who experience ACEs are at a greater risk for developing health problems later in life, including problematic substance use or substance use disorder. Having a mental health condition in childhood or adolescence can also increase the risk of problematic substance use or having a substance use disorder in adulthood. Research suggests that youth with substance use disorders also have high rates of co-occurring mental health conditions. Youth may use substances to manage a mental health condition or to cope with pain caused by trauma and ACEs. Resilience is the ability to cope with life's challenges in a healthy way. Resilience skills such as regulating emotions, managing stress, and problem solving can be developed through supportive relationships with trusted adults. One of the simplest ways to build resilience is through positive and caring interactions with adults and caregivers. Educators can play an important role in helping young people to build resilience as mentors, confidants, and trusted sources of information. Just as there are many pathways to substance use, there are also many pathways to getting well. Some people find abstinence-based programs effective. Others seek substance use services that reduce harm and help them gradually taper off their use. For example, medication-assisted treatment for alcohol or opioid use. Despite the challenges of problematic substance use and substance use disorder and their link to past trauma, many people manage to live well with these health conditions. There are several ways in which educators can support youth to learn about substance use and its relationship to trauma. They can create a safe space and opportunities for open, non-judgmental conversations about the spectrum of substance use. This can reduce stigma, fear, and shame while allowing youth to see educators as allies. They can discuss the relationship between mental health, ACEs, and substance use. And they can work with students to identify healthy coping skills and to build resilience against stress. Now, let's recap the main takeaways from this module. Substance use varies from person to person and occurs along a spectrum. Some may use substances and never experience problematic substance use or substance use disorder. Substance use disorder is not a choice, but a complex medical condition that can affect the structure and function of the brain. A number of factors can increase the risk of developing problematic substance use or a substance use disorder. These include genetic profile, family history of substance use disorder, social or economic influences, and experiences of trauma. Just because someone has risk factors doesn't mean they will develop problematic substance use or a substance use disorder. People who experience ACEs are more likely to have poor outcomes in learning, relationships, and physical and mental health, including substance use. ACEs can be prevented and their impact mitigated. Treatment is possible, and living well with problematic substance use or a substance use disorder is attainable and sustainable. We've reached the end of this module. To further support your learning on this topic, refer to the Educator's Guide for additional information and resources.
So what is addiction or disordered substance use? What does it look like? Is it having a beer every day after work? Binging on weekends? The answer is complex and it varies from person to person. In general, it can be seen as when one person persists with a thought, behavior, and/or action despite ongoing consequences. Furthermore, this behavior continues even despite the loss of relationships, social consequences, or personal impairments. A person may initially choose to engage in the behavior. However, when it becomes disordered is when one persistently uses it for positive effects and to take away negative feelings. Think of a mosquito bite. We know that we shouldn't scratch it, but the itch often becomes so overwhelming that we do it anyways, despite the injury or scab that may result. In simpler terms, addiction can be described by the 4 C's. The 4 C's of addiction: craving, loss of control of the amount or frequency of use, compulsion to use, and use despite consequences.
All the substances of abuse, whether they're opiates or cocaine or anything else, they're actually painkillers. Some of them specifically are painkillers. But physical pain and emotional pain, the suffering is experienced in the same part of the brain. So when people suffer emotional rejection, the same part of the brain will light up as if you stuck them with a knife. Then Eckhart Tolle says very nicely that addictions begin with pain and end with pain. So that all the addictions are attempts to soothe the pain. So when I work with addictions, the first question is always not why the addiction, but why the pain. And what you find is emotional loss or trauma. In the case of the severe addicts, as in the downtown East Side here, they were every single one of them traumatized. There's no women walking the streets here who had not been sexually abused, not even by accident. But you know, whether it's a sex addiction or internet or relationship or shopping or work addiction, these are all attempts to get away from distress. Keith Richards, the Rolling Stone guitarist, said, who used to have a severe heroin habit, as you know, he said that all the contortions we go through just not to be ourselves for a few hours. Or why would somebody not want to be themselves? Because they're in too much distress and too much pain. So I don't care what they tell you about genetics or any of that choices or any of that nonsense. It's always about pain. Well, the Tibetan Book of Living and Dying, it's got a wonderful line in it. Whatever you do, don't try and escape from your pain, but be with it. Because the attempt to escape from pain is what creates more pain. And that's the reality with addiction. But the question is, how can people be with their pain? Well, only if they sense some compassion from somebody. So as another teacher says, only when compassion is present will people allow themselves to see the truth. So addicted people need a compassionate present which will permit them to experience their pain without having to run away from it. And all the attempts to run away, it's like another teacher says, the surest way to go to hell is to try to run away from hell. So you got to be with that pain. You just have to be with it, but you have to have some support. And we live in a society that, one way or the other, is always about instant relief, quick satisfaction, distraction. In other words, we live in a culture that is based on, both economically and psychologically, on not supporting people to be with themselves. So it's always the quick getaway. So it's very difficult to deal with addictions in a society. But yeah, it is a matter of, at some point, finding a way of being with your pain so that you can actually get to know what it's really all about.
Scientists first began to understand addiction as a brain disorder in the 1950s. Doctors Olds and Milner, in laboratory studies of rats, found the parts of the brain affected by addiction. But then in 1994, doctors Volkov and Shelbert, top neuroscientists, ran CAT scans of the brain that showed the effects of substance use disorders. Like other diseases, these scans showed it affected tissue function. There are two main parts of the brain affected by drug use: the limbic system and the cortex. The limbic system, located deep within the brain, is responsible for our basic survival instincts. So when you do essential things to stay alive, like eat, drink, find shelter, have sex, or care for your young, your brain reinforces behaviors that cause the release of dopamine from this region. That reward for surviving is also transmitted to the amygdala and hippocampus, which records a memory of that feeling, so we seek it again. This is our survival hardwiring. Addiction also affects this area up here in the prefrontal cortex, which is what separates us from other animals. This is where decision-making and impulse control live. When drugs or alcohol are used, they activate the same dopamine process in the survival center. And when use is repeated, that substance can hijack that part of the brain. This hijacker changes the brain and weakens this system to make it believe that the primary need for survival is the drug. In hijacking the brain, it can usurp those primary motivations: food, water, shelter, sex, and protecting our young. And the hijacker needs more and more of the substance to activate the same level of reward or feeling of pleasure, causing the brain tissue to become increasingly damaged with continued drug use. There are factors that put you at higher risk for the hijacker, including individual factors like genes and age of first use, and then environmental factors like drug availability. But if the hijacker takes hold, addiction is treatable. Advancements have been made in assessments, detox, treatment programs, recovery supports, and medications to treat addiction. Brain scans show that once in recovery, the tissue in the limbic system and cortex can get better. With your help, we can expand these innovations to help millions of individuals and families and ensure that addiction is treated as the medical issue that it is.
There are many behaviors associated with substance use disorder. Probably the most significant, in addition to the aforementioned 4 C's, is the loss of control over a substance or behavior, which can lead to withdrawal and further perpetuates the cycle of use. The person who is in a cycle of disordered use may begin to withdraw from family, loved ones, or those close to them. Therefore, some signs to look out for include change in appearance, such as a drastic loss of weight, a change in attitude towards people, including being less helpful or more secretive, dropping grades, theft or noticing things missing, friends, and a change in friend groups or not hanging out around home anymore. One caveat to keep in mind is that adolescence is a time of development and transitions. As such, behaviors often change drastically, so be careful not to jump to conclusions and approach those you care about with compassion. So how does this happen and who is affected? The short answer is everyone can be. As discussed in previous sections, mental illness and substance use lie on a continuum, and various factors can make us more or less at risk of disorders. Substance use disorder does not discriminate. We're all on that spectrum. Furthermore, we should recognize that while the first time one uses a substance, they may be making a choice, disordered substance use is far beyond making a choice. It is fulfilling a need. The following will discuss some theories about what leads to disordered substance use, which have been briefly introduced in some of the previous content and videos.
When we talk about substance use and substance abuse, we have to remember that these are two different things, although they are obviously related. And although a majority of people who use substances will never develop a substance abuse problem, it is true that everyone who develops a substance abuse problem starts as a user. And so it's really important for us to figure out exactly how substance use develops into substance abuse. The first theory that I want to discuss is the gateway model. And this theory might be familiar to you. It says that some substances act as gateway drugs, meaning that their use can lead to the use of other, more dangerous substances. So here we have John. And when John was a teen, or maybe a preteen, he started experimenting with alcohol and cigarettes. And from there, maybe he starts smoking pot, he starts using marijuana. And eventually, he winds up using drugs like heroin and cocaine. So here, alcohol and cigarettes would be a gateway that leads to marijuana use, which is itself a gateway for heavier drug use. So John's early experience with less dangerous substances led him to use more dangerous substances later on. And the implication of all of this seems to be that if you can prevent people, specifically teens and preteens, from experimenting with smoking and drinking and marijuana use, then they will never move on to harder drugs. And this is the basis of a lot of anti-drug programs in the US that are targeted at preteens. And there is some support for this idea. First, the order of drug use that I've described here is pretty typical. People who use substances generally do use alcohol and cigarettes before they use marijuana. And it's also true that individuals who use heavier substances did in fact use alcohol, cigarettes, and marijuana first. But there are a few problems with this theory. The first is that correlation does not imply causation. Just because individuals have the tendency to follow a certain path for drug use doesn't mean that one causes the other. It could be that there's a third factor that's more important. Maybe any of the risk factors that we mentioned earlier. So maybe some individuals who use heroin and cocaine would have wound up using them even if they didn't have alcohol and cigarettes first. Second, this actually might be about availability. Because even though alcohol and cigarettes are not legal for minors, they are readily available. Perhaps more readily available than illegal substances like heroin and cocaine. So maybe alcohol and cigarettes are used first because they're easier for individuals to get a hold of. And lastly, only a very small percentage of those who use alcohol, cigarettes, and marijuana wind up using other substances. So it might not be accurate to say that marijuana causes harder drug use, when that's true only for a very small number of cases. A different way to think about how substance use might progress to substance abuse is a theory that focuses on a continuum of drug use. So rather than saying that one drug leads to the use of another, this theory states that a change in the pattern of substance use is what moves someone from use to abuse. So this could be a change in the amount of the substance used, or in the availability of the substance, or in the consequences of substance use. And this theory also holds that there is no one direct pattern from substance use to substance abuse. Instead, there are many twists and turns along the way. So let's talk about John again. And maybe John uses cocaine once at a party, and in one scenario, he uses and then he never uses again. But in a second scenario, maybe he uses once at that party, and maybe he intends to never use again. But maybe it turns out that one of his friends brings cocaine to a party a few years later. And he uses again. And from then on, he uses it every few years. Only in specific social situations and only when other people are bringing the substance. And we would define this as non-problem use. Alright, now let's talk about a third scenario. And this one is kind of a longer story. So in this scenario, he uses at that first party. And then, just as in scenario 2, he moves on to non-problem use. But let's say that something changes. Maybe he finds someone who is willing to sell him a steady supply. So whereas before he only used when someone else brought cocaine to parties, now he buys on his own. So there's been a change in availability and a change in supply, and that has led John to use the substance more often. And remember, as this is going on, John probably has a lot of other life changes as well. Maybe he has a new job that requires a lot of energy, like maybe he's a bartender or a businessman, and he needs a lot of energy to work late into the night. So maybe instead of using cocaine socially at parties, now he starts using it for work purposes. So that pattern of drug use changes as well. And because of all of these things, including the fact that he's using more often, maybe John moves from non-problem use to substance abuse, which, if he keeps following this pattern, can lead to a state of substance dependence. So a state where he is addicted to the substance and would experience withdrawal symptoms if he tried to quit. So this figure shows us the different pathways that people can take in terms of substance use, and also how different patterns of use might move someone from use to abuse. But I actually think that the most interesting part of this theory is that it says that people can move back and forth along these paths. So maybe John begins to realize that his drug taking is becoming out of control, and so he moves back from substance abuse to non-problem use. So he decides he's not going to use cocaine for work anymore, and he's only going to use it in social situations. And maybe after a while, he stops using entirely. Or maybe he just continues with non-problem use. Or let's say that John gets into a car accident. And after that, he's moved into a treatment program. So there's forced abstinence. And after a period of abstinence, maybe he starts to use infrequently again until he has a health scare, maybe a heart attack. That may or may not be related to cocaine use, he isn't sure. But this possible change in drug use consequences moves him to abstinence again. And so depending on all of these different circumstances, all of these different life changes, drug availability, the amount that someone is using, why they're using that substance, even things like whether or not they have money or being put in prison or moving to a new town. All of these changes in patterns of drug use can lead to either an increase or a decrease in the amount of drug used depending on what those changes are. Another interesting thing that you can notice about this theory by looking at this figure is that it says that someone can't move from a single use directly to problem use. Instead, they have to pass through non-problem use first. So this theory is pretty clear in its statement that addiction is a process. It's not something that happens right away. And one other very important part of this theory is that it holds that this cycle is repeated individually for each substance. So maybe John tries cigarettes once and then never uses them again. And maybe he used to drink alcohol once in a while, but then stopped when he reached middle age. And maybe his cocaine use, as we've been talking about, follows a more complicated path along this figure. So this is very different from the gateway theory, which holds that using one substance can lead to the use of another substance. Because in this model, each substance is considered individually. And because of this, this continuum model winds up being a lot more complicated than the gateway model. But because it has this added complexity, it might be a more realistic way of looking at how people move from use to abuse.
Although substance use disorder can affect anyone, there are certain people who are more vulnerable than others. One way to understand this is through what we call the biopsychosocial model. This model is not only a holistic way to understand substance use disorder, but is also helpful to professionals in terms of pathways to wellness. The model is broken down, as the name suggests, into three elements or dimensions that combine to influence people. Biological, or the inner circle. This may be considered the basis of the medical model, which can be thought of not only as genetics and internal systems, but how the substances change the brain functioning in a reciprocal manner. Many may have heard that addiction is inherited or that the reward pathway in the brain is attributed to substance use disorder. Well, those are both partially correct, but there's more. Psychological, or the middle circle. This dimension, in short, is based on both behavioral and cognitive psychology. The theory of operant conditioning describes how reinforcements and rewards, or punishments, shape our behaviors, while the cognitive aspect describes one's perception of events and the ability to cope with them. Combined, these explain how and why people living with substance use disorder behave the way they do. Social, or the outer circle, it's often thought of as our environment, the world around us and what influences us. This can include our immediate family, friends, peers, work acquaintances, or cultural factors. These influence the biological dimension in both how and which genes express themselves, as well as the psychological realm of conditioning and rewarding responses. It is important as well that a structural and intersecting lens is looked at in this dimension as well. Factors such as class or socioeconomic status, race, and gender have an influence on how we are affected by our surroundings as well. All of these factors combine to form the environment in which we live and affect all our lives. Perhaps just as important as how these factors combine to create a disorder is how we can use the same framework as a tool to view recovery. Briefly, for example, biologically, pharmacological interventions or medications can help with cravings or chemical imbalances. Psychologically, we can help by creating new, healthier reinforcements and rewards to rewire the pathway and use theories of motivation and change. Finally, socially, we can help our loved ones understand the people, places, and things that surround them that may be promoting substance use behavior or keeping them in a cycle of use.
As it turns out, only a very small number of substance users become substance abusers. And this is something that we really don't know too much about. We don't know why certain people but not others move from use to abuse, and we don't really know how use generally progresses to abuse. But even though we don't have a complete model, we do have a number of theories that pertain to this. And that's what I want to go over in this video. The first model I want to talk about is the common syndrome theory, which is also sometimes called the problem behavior theory. And this theory revolves around the idea that maybe there is one single underlying factor, a drug use propensity, that might put people at a higher risk for abusing substances. But this is really deterministic. It kind of implies that anyone who has a drug use propensity will develop substance abuse problems. And that seems pretty severe. A more nuanced way of talking about this is to use what researchers sometimes refer to as the Swiss cheese model. So here we have a piece of Swiss cheese, and of course it has holes in it. So imagine that every individual on Earth is a unique slice of Swiss cheese. So the placement of holes on each individual slice and the size of these holes and the number of holes vary from person to person. And so we can imagine that the solid parts of the cheese represent things that can protect us from substance abuse. And so the more solid area you have, the less likely you are to use substances. The holes, on the other hand, represent risks. So individuals with many holes or with really large holes would be at a greater risk for substance abuse. So maybe we can imagine someone whose friends use substances and that opens the door for their use as well. Or maybe they have a relative with a substance abuse problem. And in fact, there are many different types of risk factors for substance abuse. And we can think about these different risk factors as being individual slices. So let's say that we have 3 slices of Swiss cheese here, and each represents a different kind of risk factor. So we have biological risk factors, things like genetics, psychological risk factors, so maybe certain personality factors that are correlated with addiction. And we also have social risk factors, things like having friends who use substances, which we talked about earlier. And of course, these slices are different for each individual person. They might have more holes in one and fewer in another, but everyone has some unique combination of risk factors. So now let's try to use this as a way to talk about why some individuals develop substance abuse problems and others don't. And to do that, I want you to imagine that you're shining a laser pointer through these different slices of cheese. So I have 3 laser pointers here, and these laser pointers represent substance use for different individuals. And if the light hits a piece of the cheese, it'll stop. But if the light goes through a hole, it will continue to move forward. And it is only when the light reaches the back wall, only when it has passed through all of the holes and in the right combination, will someone develop addiction. So let's say we have someone who uses substances, but they don't have a lot of risk factors. They don't have a lot of holes in their Swiss cheese. In that case, the cheese will block the laser pointer beam, and the person will not develop addiction. But let's say that we have someone else who does have some risk factors. Maybe they have a relative who has a substance abuse problem. In that case, some of the light will get through. But if they have fewer holes in their other Swiss cheese slices, or if they aren't lined up in the correct pattern, then the light will stop there. But imagine we have someone else, and maybe they have a lot of holes in their Swiss cheese. They have a lot of risk factors. Or maybe they have an average amount, but they're lined up in a very particular way. In this case, the laser will be able to shine directly through the holes of the Swiss cheese for all of the slices, and it will illuminate the back wall, meaning that that person will develop addiction. And hopefully I didn't confuse you too much with this laser pointer Swiss cheese model. But the takeaway is that each individual person has a unique combination of risk factors, or things that will make them more likely to abuse substances. And while a lot of individuals might use substances, substance abuse problems will only develop when these risk factors line up, so when they're combined with each other at the right time.
What if someone experiences a mental illness at the same time as a substance use disorder? Co-occurring mental health and substance use disorders are commonly known as concurrent disorders and are very common. Having a diagnosis of one greatly increases the risk of the other. One study found that those with mental health disorders were 3 times as likely to have a substance use disorder over their lifetime, whereas those with a substance use disorder were 4.5 times more likely to have a mental health disorder over theirs. A more recent analysis states that over a lifetime, half the people with one disorder will experience the other. It may be difficult to comprehend if we think of it in terms of which came first, like the chicken or the egg, and is therefore suggested that, since they interact with each other, they are seen as 2 separate issues that are reciprocal in nature. Knowing what we do now about the biopsychosocial model, it is apparent how these could interact.
The correlation between mental health and addiction is clear. In Canada today, millions of people have co-occurring mental health and addictions disorders. This issue is a growing concern. As the number of Canadians looking for help with mental health and addictions grows, the need to improve the quality and accessibility of treatment services to meet these complex needs is clear. While we've made some significant progress, we need to do better, especially when it comes to putting in place treatment and supports for co-occurring mental health and addictions needs. Because the reality is that for too many Canadians, these services are not easy to access. Canadians have to navigate a complex and exhausting system to access the services they need, and too often their needs are not completely met. The need for collaboration is important so that we can deliver effective treatment and support for individuals and for our communities. Across Canada, some jurisdictions have recognized this need and have made the move to combine mental health and addiction services successfully. Todd Leader is here to talk to us about what successful collaboration looks like in Nova Scotia.
When it comes to these psychosocial and behavioral and emotional kinds of issues, we have to start to recognize that it's a whole person and those pieces are integrated. From an administrative perspective, people automatically jump to the structural piece and think that, well, as long as you put those two programs together under the same director, then you're integrated and things will just happen. And that's a superficial kind of approach, and it's based on administration, not on the way people actually behave. One of the most common approaches used in this is, besides the structural piece of just creating a single directorship, is the idea of physical co-location. So you'll see people doing that as well. Just put everybody in the same building, sharing a hallway, and they will start to function as one. But there's no evidence to support that. But the real work of creating true integration actually happens at a social psychology level. It is about how groups relate to each other, view each other, interact with each other, and conflict or become one with each other. The kind of things we need to do to get past that part, after we put them together in the same space, we need to create interdependence between them. We need to create collaboration and interdependence, which really means we need to create opportunities for them to need each other, not just to work in the same hallway as each other. That interdependence actually helps them change their definition of who is us and who is them. It will mean less bureaucracy in terms of referrals and paperwork and having to go through various assessment processes. It will mean not having to go to a second person to tell your story again. By integrating, at a superficial level, we got to say, well, what would be best for the client? A single client. And it would be a single phone number. Quite simple. No confusion, no stress trying to figure out where to go. A single intake system with nice people on the phone to talk to and who can make sure that they get the treatment that they need for their variety of issues, for their combination of issues. Being able to see one person, one therapist, and unless there was some level of complexity or uniqueness that required more intensive work, then that one person is all you would need to see. And so for a client to be able to come in and just see the one person and not have referrals and not have multiple appointments and not have to tell my story to two strangers instead of one. From a client perspective, that is a miraculous change.
Recently, the Canadian Centre on Substance Abuse partnered with the Canadian Executive Council on Addictions and the Mental Health Commission of Canada to consolidate knowledge and generate consensus on effective approaches and strategies for enhancing collaboration between mental health and addiction services. This partnership led to the publication of the Collaboration for Addictions and Mental Health Care Best Advice document and an online collection of tools and resources to support collaboration. Both resources can be downloaded from the Canadian Centre on Substance Abuse website.
Are those struggling with mental illness and or substance use crazy? Are they junkies? Did they make their choices? Unfortunately, discrimination and stigmatizing language like this are common among those who do not understand mental illness and substance use disorder. Stigma can be defined as an attitude, belief, or behavior that discriminates against people. Often derogatory language, stigma can lead to shame in both substance users and their families and can create barriers to seeking service as well as the quality of the service they receive. It is pervasive, and unfortunately, we hear stigmatizing terms often and witness attitudes, even within the healthcare setting. Fortunately, we can make simple changes by using appropriate person-first language and beginning positive conversations regarding what we know about substance use and mental illness. Countering ignorance with education and using an empathetic approach will always facilitate people feeling like people.
If you really cared about anyone but yourself, you'd stop being a useless addict.
You promised you'd never do that again. Stop saying it'll be different this time. It never is. You're just a loser.
You're so stupid. How are you going to pay the bills? What are you going to do? Do you give a crap about anything?
You're a waste of breath. Don't tell me you care. There's no proof. I hate you. I hate you. I hate you!
I can't stand the sight of you.
If you think that name calling and shaming us is going to help,
We want you to know.
We've tried that already. It doesn't work.
the day my life changed, I met someone who said they knew I cared. That maybe I just needed to learn how to change, not how to care.
I always remember the feeling of being understood for the first time. Acceptance.
Once I realized that my brain had been hijacked and I wasn't thinking straight, I started working at changing the way that my mind works. It wasn't long before my life changed as well.
I'm still struggling. I now see that the me in me is doing the best to change my life. Not giving up and doing my best today, even though people don't always understand. It's better because now more people talk to me like a person. That's good. It helps, because I am one.
Hi, I'm Gord Carter from CAPS. Language is a powerful tool in helping people with substance use disorders. Please choose person-first language, speak about the person, help reduce the suffering. You can make a difference here in Canada for your friends, your family, your neighbors, your community. For more information on how to use person-first language, go to our website www.capsa.ca/resources. I want to say thanks in advance. I know that you want to make a difference.
All right, let's do it again. For a split second, okay?
Okay.
Yeah, absolutely.
Yeah, you can. That'll be like some special moment.
It's really a tragedy when we see young people in particular internalize stigma to the point that it becomes deeply held shame, and shame that really holds them back from being able to attain wellness and recovery. I've dedicated my career to helping people who are suffering from substance use and mental health issues, and there are countless stories, and particularly those with youth. The thing that always strikes me is the sadness and the hopelessness that we encounter, but we know that recovery is possible because we witness it every day. And one of the ways in which we witness that is we see the hope back in people's eyes. They start dreaming again, they start seeing a future for themselves, and that's really powerful and very rewarding. Well, we all have a role to play, a really important role. I think in large part it starts with how we refer and talk to individuals who are suffering from substance use disorder, person-first language, recognizing them as people first, and understanding that they didn't choose this. This isn't a moral failing. This isn't something they've asked for, and we don't have a right to impose judgment on them. We're there to help.
I had scored. I want to ask you again to send us an email, get involved with our video production, info@capsa.ca. Let's make a difference here in Canada. Let's start with you.
Stigma ends with me.
Stigma usually begins with prejudices or simply not knowing. These often stem from myths about mental illness and substance use. Here, we will address a few common misconceptions in regard to these topics. Harm reduction. Perhaps you have heard the term harm reduction is simply giving people who want to use a safe supply. While that is part of an approach to reduce harms, much like anything else, it can vary from person to person. One definition defines harm reduction as policies, programs, and projects which aim to reduce the health, social, and economic harms associated with the use of psychoactive substances. It is an evidence-based and cost-effective approach, bringing benefits to the individual, community, and society. So to some, it may be safe injection sites, whereas to others, it may be simply reducing consumption or changing behaviors with the help of a counselor. We all use harm reduction to some extent in everyday life, whether it be putting on a seatbelt or looking before crossing the street. There are many other myths regarding substance use that one might hear floating around. Here, we'll address some that are common. Those living with substance use disorder do not have the willpower to stop. As discussed in a prior section, we now understand that substance use disorder has very little to do with willpower or choices. It's a complex combination of biopsychosocial factors that are unique to each person and influence how and why they make the choices they do, and often use to escape a negative feeling. Prescription medications are safe. While prescription medications can be beneficial as pharmacological interventions, and when used as prescribed, 14% of young adults, 18 to 25 years of age, used a prescription medication recreationally or for non-medical use within the past year. They have the potential to be as dangerous and deadly as illicit substances. However, when used properly, medication can be an essential part of the individual's wellness to effectively address underlying mental health issues, and when untreated, the individual is at a greater risk of relapsing or recurrence due to the desire to self-medicate. Marijuana is not addictive. According to the National Institute of Drug Abuse, referred to as the NIDA, 30% of those who use marijuana have some form of disordered use. The chances of developing a disorder as an adult multiplies by 4 to 7 times if the use begins before the age of 18. This can result in exacerbating symptoms of depression, impairment of cognitive function, induction of psychosis, a higher risk of schizophrenia in those who are predisposed, as well as worsening symptoms with those who already live with the disorder. Medications during treatment, such as methadone, Suboxone, or naltrexone, are just substitutes for the substance. These medications are used in combination with doctor's supervision and treatment, which usually include therapy and counseling. Furthermore, these medical interventions can help with withdrawals, which can be deadly without supervised detox and medication, cravings, or management of recovery. These pharmacological interventions, in combination with treatment, have been shown to be effective with alcohol use, opioids, and more. We know that substance use disorder has some neurobiological basis, so these medications are just another tool in the toolkit. If you relapse, you're back to square one. A person's respective pathway to well-being is not linear, and there may be recurrences of substance use along the way. Difficulties such as emotional pain, trauma, and transitions to a different way of life can get in the way. Learning to live without substances or with reduced substance use is exactly that, a learning process. It's highly unusual for there to be no missteps along the way. It is all about the journey, not the destination, and everyone forges their own path. What this adds up to is that while we may feel the need to place blame on someone or something, it is important to remember that this is not the person who is using the substance's fault, nor is it your fault if you are the caregiver or a loved one.